Good afternoon, everyone, and welcome to the Lynn Cancer Institute updates. We're keeping you in the know in 2024. We're very grateful to have you all with us today, and we're going to learn from our very own Lynn Cancer Institute physicians who will educate us on prostate cancer. At the Lynn Cancer Institute, we believe that education, prevention, screening and early detection, a variety of treatment options, the expertise of our staff, and our latest technology will truly save lives. In the interest of time, our physician bios were sent to you by email. During this presentation, we encourage you to take notes. And if you have any questions, please put them into the chat box or the Q&A box, as the speaker will not be able to see you or hear you during their presentation, and we will have time at the end of the presentation to answer your questions. Now, we're very proud to welcome you to our Lynn Cancer Institute and to introduce Dr. David Taub, urologic oncology and surgery specialist. Thank you, Dr. Taub.
Thanks, Jan. I'm going to share my screen. Can everyone see my screen now?
Yes.
Perfect.
And it's on slideshow, so it's perfect.
Perfect. So Dr. Saeed, Dr. Bacco, and myself are going to give some updates of what we're currently doing at Lynn Cancer Institute to offer the latest and most modern medicine to our community. And we're thankful that you have the chance to join us. Please feel free to ask any questions at the end. We'll certainly get to all of them. So quick overview of what I'll be talking about. I'll talk about a little bit about the state of prostate cancer, how we screen, and then how we treat it from a surgical perspective when it's curable in its earlier stages. So I'm a urologic oncologist. What I do every day is treat cancers of the urinary tract and male genital tract. Prostate cancer is the most common cancer in American men, with nearly 300,000 new cases in 2024 and approximately 35,000 men dying from their disease this year. We also take care of bladder cancer, kidney cancer, testicular cancer, and the adrenal glands that you see just on top of the kidneys. So what is the prostate? The prostate is a male reproductive gland. It adds nutrients and fluids to support reproduction in the semen, and the urinary tract in men runs right through the prostate. And as the prostate grows, it kind of impinges on the urethra and can cause some urinary problems, which really have nothing to do with cancer most of the time. And so that's oftentimes why men see their urologist, is to talk about their prostate problems. The average age at diagnosis is in the mid to late 60s. When you go to a restaurant, you look around, probably one man at every table has been diagnosed with prostate cancer, or will be diagnosed with prostate cancer in their lifetime. 1 in 8 American men. Risk factors for more aggressive disease or earlier onset of disease are genetic mutations. Certainly the BRCA gene, BRCA2, connotes a 35 to 50% chance of cancer, and we see those cancers be more aggressive and show up at an earlier age. Family history in father and brother at a younger age, under age 65, is a risk factor. African American men tend to have more aggressive and earlier disease, and as men get older, they tend to get prostate cancer, so advanced age. So mortality has gone down over time a little bit with screening, with PSA testing, with prostate exams, with MRIs. We'll get through that. But over the past several years, guidelines have been a little bit less stringent on monitoring and screening for prostate cancer. And because of that, we have seen a little uptick in mortality rate and advanced disease. So how do we screen for prostate cancer? Generally, it's men aged 45 to 75 with a life expectancy of at least 10 years. So when we first diagnosed early stage prostate cancer, it takes many years for it to grow and spread and cause a problem. So sometimes later in life, we have a little bit less stringent oversight on that. So for higher risk men, we start even younger, maybe up to age 40. We take a medical history, smoking, dietary, family history. We do a prostate exam and a PSA, or prostate specific antigen blood test. And if any of these are abnormal, that's what your primary care physician would do. You would be sent to a urologist who might order an MRI or talk about doing a prostate biopsy. So we used to just do kind of templated, or some people thought random prostate biopsies, and we would detect a lot of cancer, but it wasn't always aggressive or clinically significant. And the MRI about over the last 10 years has really, with updates in the hardware and software, just like our phones are so powerful, the MRI has really become a powerful tool for us to diagnose any abnormal spots in the prostate. We copied our colleagues in breast cancer and came up with a high-RADS scoring system for prostate imaging abnormalities, and it's from 1 to 5. A 3, 4, or 5 would be higher risk for cancer and require additional testing. And what we do is we do what's called MRI ultrasound fusion biopsy of prostate. So we have an ultrasound probe in the rectum that has a live image that visualizes the prostate. And then we have these stored MRI images that we overlay onto the live ultrasound, and we can target some things that may show up on the MRI but may not show up on the ultrasound. And it basically helps us detect more significant cancers, clinically significant cancers at an earlier stage, and we can avoid just doing some random biopsies and detecting kind of some less aggressive or less severe cancers. So treatment options for prostate cancer depend on the patient's overall health, their age, the aggressiveness of the cancer, the stage or extent of disease, volume of disease, patient's personal preference. Dr. Saeed will spend some time talking about radiation, which does a great job, just like surgery. And another thing that helps us is genomic testing. It helps us personalize our care to the patients who are, coming in. We can give much more precise information. So we use this Decipher genomic score, which is a tissue-based test. So it's from the biopsy that we already took, and no additional procedure is required. And the report kind of looks like what you see there. The results are from 0 to 1, where the higher the number is more higher risk and the lower is lower risk. And it may help us choose the right treatment option for each patient. And then we get some more information on the lower part of the report that talks about risk of metastasis at 5 or 10 years, risk of mortality, etc. So the test examines the expression of 22 genes that can help identify tumors that are more likely to spread outside the prostate. So this is we're really fortunate to practice medicine in this beautiful building, Lynn Cancer Institute. It's undergoing a little construction right now because we're going to add a nice proton center here as well. But it's right on the campus of Boca Raton Regional Hospital, and what we like to do is putting the patients first, is have a multimodality clinic where new and complex cancers can come and see a medical oncologist like Dr. Bacow, a radiation oncologist like Dr. Saeed, a surgical oncologist like myself, a genetic physician like Dr. Morel, and then we have specialists in radiology and pathology, social work, and nutrition help to support the whole patient. And we offer clinical trials for different complex or advanced cases. So different treatments right now in 2024. One good treatment is active surveillance. It's no treatment. So if we detect cancer at an early stage, it's not aggressive. There's been good data showing that at 10 and even 15 years, that it may not spread. And so some people can be fortunate just to be watched with their cancer and not actively treated. But we also have a very precise surgical approach called robotic prostatectomy. And we have new surgical approaches which ablate just the focus of cancer and a rim of normal tissue around it, and leave the majority of the prostate alone to lessen side effects. So for robotic prostatectomy, the goal is to remove the cancer. High cure rates for localized disease. With the robotic approach, we're able to preserve urinary function, sometimes improve it if the prostate's impinging on the urethra. We're able to preserve erectile function and analyze the prostate after surgery to assess risk of recurrence and need for additional treatment down the road, potentially radiation therapy. So here's a quick overview of the robotic system we have. We have the latest intuitive surgical system. It is a computer enhanced system. The surgeon operates at a console, and there is an assistant next to the patient at the bedside, and the surgeon is immersed in a 3D magnified image of the surgical field. This shows an example of how kind of small and precise the instruments are. They fit through dime-sized incisions. There are wristed movements like a human wrist, which really allows increased precision, dexterity, and maneuverability in very tight spaces in the pelvis. Finally, I'd like to share what we're doing newly here this year. Starting in February, we've been using focal therapy. And what this does is it takes our advanced imaging, our targeted biopsies, our genomic testing, and we can really localize the disease and better stratify the patient's risk and personalize their care. This is not for every patient. It's not for very aggressive disease. It's not for very high volume disease. It's for early disease, low and intermediate risk. And what we use is something called HIFU, which is high intensity focused ultrasound, which provides ablation of the prostate lesion and a small area around it. And this can be also used in the rare case of radiation failures. So the way we look at this is the diagram shows one or two lesions of the prostate, and we can treat in a quadrant or kind of a hemigland approach to spare a lot of normal prostate tissue and thus even more preserve sexual and erection, sexual and urinary function. And so it limits toxicity. And again, it's just for select patients. There are different. We've been using cryotherapy in the past. There's interstitial laser ablation, irreversible electroporation. There's all sorts of different energy sources, but we found HIFU to be more precise and have been able to deliver that to our patients this year. We've treated over 30 cases so far. So this is just a smattering of references of data, but it's been used in Europe for many years, for like 20 years, and been well studied. Patients need to be followed closely because there is a slightly higher risk of recurrence because you're leaving part of the prostate untreated. This is the machine that we use called Focal One. There's 3 in the whole state, one at the University of Miami, one at the University of Florida, and one here. And we are excited about being able to deliver this type of care to our patients so that they have really a true comprehensive approach to their prostate cancer care. So that's it for me. I'm going to turn it over to Dr. Saeed and let her speak to what we can do for you from a radiation standpoint.
Yes, it's perfect.
Okay, excellent. Thank you. So thank you all for having me here. I'm Dr. Said, one of the GU radiation oncologists. So today we'll be talking about prostate cancer with a slight more focus on the radiation aspect of it. So again, I won't go into too many details about it, but because Dr. Tobe did a very good job in explaining this, but essentially it's one of the most common cancers in American men. 1 in 8 men will develop prostate cancer in their lifetime. About 6 cases in 10 are diagnosed in men who are over the age of 65. Incidence increased by 3% per year overall, and by about 5% per year for advanced stage disease. So roughly around 300,000 new cases of prostate cancer will be diagnosed in the US, and around 35,000 men will die from the disease. So important to know that any early detection through regular screenings can significantly improve treatment outcomes and the options available to any patient. So what are the treatment options? Broadly speaking, which are standard of care and recognized all over the world, active surveillance is one of them, especially for very early stage disease. Systemic treatment, which Dr. Bacow will be talking about more in detail, kind of combines hormone therapy with some immunotherapy, with some chemotherapy options. And then local and curative would be surgery plus minus radiation. And radiation can do its job by itself as well, and we'll talk a little bit more about it in detail. So why radiation? So radiation has an excellent record of treatment success. About 2/3 of patients of any cancer, of all cancer patients overall, will need radiation at some point during their journey. Radiation provides long-term disease control with survival rates equivalent to other forms of treatment. Like other treatments, radiation therapy also has its own benefits and risk that may affect patient's quality of life. Because the long-term survival rates following treatment for prostate cancer have improved, the impact of treatment on a patient's quality of life may influence its choice of treatment. So many a times our patients do not have, will only be choosing a modality based on the side effect profile versus the efficacy profile. So what is radiation? It's really an X-ray. So the difference between a regular X-ray and the radiation that we use is the energy, which is supposed to be a high energy X-ray that interacts with the DNA of the cancer cell and damages the DNA. So we call radiation as a double-edged sword. It damages the DNA of the cancer cell, but at the same time, it hurts some of the normal tissue cells as well. The good thing is that it preferentially damages the cancer cells over the normal tissue cells that can repair the DNA, unlike the cancer cells that do not have the ability to repair the DNA. So what are the radiation delivery options? It can be delivered in 3 different ways. So external beam radiation therapy, which is really going to be the focus of this conversation, and that's going to happen via X-rays or particle beams. Internal radiation, aka brachytherapy, which we do have. Radiopharmaceuticals, which is our newest addition to Lynn Cancer Institute, which really ordinarily goes by the name of Pluvicto. So how do we deliver radiation? External beam radiation therapy usually this is the most common one that you're going to come across. So several days to weeks course, delivered in overall like 3 different ways: conventional or standard fractionation, which is the longest course that can sometimes be used for high-risk patients; hypofractionated radiation therapy, typically used for some intermediate cases; and then ultra hypofractionated or SBRT approaches, which is a really high dose of radiation per treatment. When can radiation be used? Now, this is important to note. It can be used in 2 different settings overall: localized disease and metastatic disease. When it is used in the localized setting, it is used with a curative intent, and there are several different ways in which we can use it. We can use it on its own, and it can be used in conjunction with androgen deprivation therapy that Dr. Bacow will talk to you in more detail. Or it can be used in the adjuvant setting after Dr. Tobe has done a surgery, and at that point too, sometimes we add hormones, sometimes we don't. Or it can be used in the salvage setting, meaning that patient has undergone surgery, but the PSA continues to rise, and we know that it has come back in the prostatic fossa. In the metastatic disease, it can be used with two different intentions, non-curative and curative. In the non-curative setting, sometimes radiation can be used to improve quality of life, such as to manage pain, to make sure that any bone or any spine is affecting. We are giving some radiation to prevent the progression of lesions that can cause a spine to become unstable. Or if, let's say, if it comes close to the cord or the nerve roots, to prevent the progression of any metastatic lesions that can result in functional compromise. In the curative intent setting, now this is important to again know, there is increasing indication to use radiation therapy. And in those settings, there's a lot of data coming in where radiation will be used not just to treat the prostate, but also to the limited sites of metastatic disease with curative intent. So people who were practicing, let's say 20 years ago, 25 years ago, radiation was very different in that time frame. People would just deliver radiation. The beam of radiation would come from come from maybe one or two different angles, and people would just hope that there are no side effects. So this really, like over the past 100 years, we were kind of like slow for quite some time until in the last 20 years, the treatment technology really picked up. So anywhere after 2000s is really that you're going to see major advances in the field of radiation technology and delivery. So we started with advancement in software imaging, followed by 3D era, where we had the capability to transform dose in 3 dimensions. Then came the IMRT, which is another very fancier technique. Then came image-guided radiation therapy that allows us to see the prostate on a daily basis and move our radiation fields according to the image that we are getting on a daily basis. Then the volumetric arc therapy, which essentially is a multiple beamlets going around the patient, delivering dose in teeny tiny beamlets so that where they converge, that's a focal point of dose delivery. And in this way, we protect the other organs. Then came stereotactic body radiation therapy, which is high dose per fraction and is given with very tight margin and with excellent image guidance. Then radiopharmaceuticals, which is a Pluvicto which we recently acquired, and we'll be treating our first patient soon here. And then proton beam radiation therapy, which is currently in the works. And we'll talk about all of these options a little bit more in detail now. So why Lynn Cancer Institute? You might say that I'm biased, but I do feel that we have a very strong team of multidisciplinary experts sitting all across and talking about things. Nobody's voice is higher than the other person. We discuss each and every patient in the light of data, and that's how we make our decisions and recommendations. We have state-of-the-art technology. There are very few community centers out there who will have such technology as what Lynn Cancer Institute has. Some academic centers will have it, but not even all academic centers will have the range of technology that we are very fortunate to have. And the credit of that goes to all of you people who donated to us. We have the disease site expertise that patients will be looking for. We have a team of radiation oncologists discussing every single case. And then we have an array of supportive and ancillary services for our patients. At Lynn, we strive to deliver excellence with compassion, and we focus on quality and safety. So how do we start radiation? So we pre-plan the radiation by taking our patients initially to a procedure suite, whereas we sometimes can place what we call a gel or a spacer between a prostate and a rectum to minimize the side effects. Approximately 1 week after that, we do what we call a CT simulation, which is done by the radiation therapist, where we immobilize, place the patient on a table, and we use a little bit of a cradling to immobilize the patient. We try to get a scan done with a full bladder and an empty rectum, and oftentimes we also use an MRI for radiation planning. There's a team of physicists and dosimetrists with the physicians. Dosimetrists are people that take the prescription dose from the physician and try to carve out the dose again, around the organs at risk and focus more on the target. Physicists are really the gatekeepers of the quality and safety in our department, who make sure that every plan looks great and is deliverable. So we, as radiation oncologists, would take information from the biopsy, imaging scans, and physical exam. We fuse the scan fusion is done by the dosimetrist using a CT simulation scan and an MRI. Then the physicians would do the contouring, and the quality and safety checks are done by the entire team of radiation oncologists. Each plan is unique and highly individualized, very precise, highly conformal, accounts for all motion, and the goal is to focus the radiation beams on the prostate while limiting radiation dose to healthy tissues around it, such as the bladder and the rectum. And then the plan again goes through another check, emphasizing on quality and safety by all the other radiation oncologists. And after that, it goes through a physics check. Hence, there's always a few days of delay from the time you're scanned to the time you start your treatment. So how do we deliver treatment when you come in for daily treatments? There's some prep that's involved, and where the patient really controls how they're doing. We would ask them to have a comfortably full bladder and an emptier rectum. As when they come inside and when they're lying on the table, we do an we acquire an image very quickly to make sure that they're lining according to the parameters that we have already defined. And then we keep an eye on how things are moving internally. The radiation by itself is just a few minutes long. It's painless. Radiation enters, exits your body. The patient will not be radioactive and nobody will be glowing. Sometimes I often hear patients saying, I hope it's working. I don't feel anything. That's because all they hear is a machine buzzing around, but it's kind of non-consequential. So again, at Lynn, we really have the entire gamut of equipment. Our main discussion during our meetings in general is not better can we treat the patient. The discussion revolves around what tool do I use to treat the patient. It's almost like going into a kitchen and having an array of pots and pans, but you're not going to be using a pan to make a soup. So knowing how to do things and what things to do and what tool to use is essential. So we have the variant TrueBeam, Radixact, CyberKnife, and Meridian. So TrueBeam, again, I won't go into the details of it, but it's a remarkable machine that acquires a really nice cone beam CT on a daily basis, allows motion management using according to the respiratory cycle. And just to kind of give you a quick snippet around it here, so that's the prostate, those are the femoral heads, that's the anterior part of the body, that's the posterior part of the body, and this is where the high dose is located. So Radixact, another very nice machine with a helical design, and that delivers dose continuously as the patient's table moves. So it revolves around the patient while thousands of beamlets are delivered to the tumor. And it also has real-time motion synchronization. So I typically use this machine when I'm treating the lymph nodes as well as the prostate because of the helical delivery of radiation that allows me to really be very precise in my dose and not get a lot of dose delivered to the cord or to the bowel in front. So CyberKnife, another really nice machine used for high dose treatment per fraction. And this is just another picture showing how the CyberKnife plan looks like. Again, this is a prostate right now, and it makes a dose, it makes a very tight bubble of radiation go directly to the prostate. So Meridian, this is the newest addition to our system here. Basically, it's a unique combination of MRI and radiotherapy linear accelerator that provides imaging and treatment at the same time. So while with this, we can have soft tissue resolution of how the prostate looks like, how the bladder looks like, how the rectum looks like. You can actually see an air bubble go through the rectum as you're delivering treatment, and the machine automatically knows when to stop treatment as a bubble goes through the rectum and deforms the prostate. So in this one, this is a machine that I oftentimes use when I'm delivering a high dose per fraction. even for longer fractionation schemes. So in this one, if you look here very carefully, this is the prostate right here. This is the rectum. This is a very high dose going right in that corner where there was a high Peyrat's lesion detected per MRI. And right here, you can see it. So Pluvicto or lutetium-177, we have started offering this treatment as well to the patients. So this is a targeted radioligand therapy that binds to PSMA-specific cancer cells. It's indicated for advanced prostate cancer, especially for those cases that are resistant to other treatments like hormone therapies and non-hormonal treatments. So according to one of the trials, patients who got this treatment tended to live longer, had delayed progression of radiographic disease, and then it allows some shrinkage of tumors. Okay. So this is what we are very, very excited about. So we are going to get the next generation of proton therapy in Palm Beach County. This is super innovative. It has a robust optimization software, and we are very, very fortunate to have a very skilled team of proton physicists who not only have the clinical experience to engage in proton delivery, but are also heavily involved in research around this, even before the protons actually come in. So this was a presentation that was given by the director of our physics, Dr. Rana, back in PT Cog over the summer, where he went and explained about how a partial single arc for prostate SBRT would be a feasible approach for prostate cancer. And this is one of the plans that he put forward. This is where the high dose would be, and this is where the low doses would be falling the line. The cyan line is the low dose. So again, this will be state-of-the-art program. Don't know of any other place that will be offering such an innovative proton program at this point. So what are the side effects of treatment? So if you look at this picture carefully, the bubbles to the left are what the patient is more likely going to experience. The darker the color of the bubble and the bigger the bubble, the more likely they're going to experience that versus the other side. So essentially like urinary frequency, urgency, some straining problems, mild transient fatigue, loose stools, diarrhea. And for the long term, erectile dysfunction, urinary frequency, urgency, rectal urgency, and loose stools, diarrhea. So in the future, where do I see the field going? So I would say that I'm looking at more use of radiation in the localized setting as well as in the metastatic setting. Why? Because we are becoming more targeted, we are becoming more precise, our success rates are getting better, we are seeing the side effects, we are seeing much less side effects than what we were seeing before. There's some convenience to this offered to the patients, fewer treatment sessions, and less disruption to daily life. My patients who are working continue to work. The patients who are not working continue to have a more vibrant social life than what I have. So thank you, and happy to take any questions in the end.
Thank you, Dr. Saeed. Next will be from Medical Oncology, Dr. Spencer Bacco.
How about now?
Yeah.
Perfect. Now it's perfect.
Wonderful.
Thank you.
Yeah, sorry about that. My name is Dr. Spencer Bacco. I'm a hematologist oncologist here at the Lynn Cancer Institute, and I specialize in genitourinary cancers, gynecologic cancers, and cancers of the blood and blood-forming organs as well. And I don't do surgery or procedures like Dr. Taub. I don't administer radiation like Dr. Saeed. I treat patients with prostate cancer with medical therapies, whether it's targeted therapies, hormonal therapies, chemotherapy, immunotherapy, etc. And I have to say, this is although I hate prostate cancer, it's a very exciting time in the medical management of prostate cancer. We have all kinds of new treatments. We're combining older agents with newer agents. We're seeing unprecedented changes in survival. And we've really changed this disease from one that's been very morbid to one that's more of a chronic disease like essential hypertension or diabetes mellitus. So couple things I want to talk about. Patients, they either go their prostatectomy for their localized prostate cancer or they get radiation therapy for their localized prostate cancer. The standard of care a lot of times is to monitor the PSA, and when the PSA starts rising, we look to see if there's any macroscopic pieces of tumor that we see on scans. But what we usually do, a lot of times, we don't see macroscopic disease, and we just see rising PSA levels. And a lot of times we know that the most likely site of recurrence is usually where they did surgery before surgery was done. So a lot of times we do radiation therapy after surgery with or without hormonal therapy. If the patient's had radiation therapy previously, salvage prostatectomy can be done, but per my urology colleagues, that can be technically difficult. There are other focal therapies that Dr. Taub talked about now that we're using more, such as cryotherapy and high-intensity focused ultrasound. But what I want to talk about is the patient with what's called biochemical recurrence, or PSA-only disease. We know those patients that don't have any metastatic disease, that just have a rising PSA, they are at risk for developing metastatic disease. So how can we delay the time to that happening? And a lot of times we've given hormone therapy to people, which is where we bring the testosterone levels close to zero. Prostate cancer comes from prostate tissue. It's the male organ, feeds on the male hormone testosterone, and bringing it close to zero helps bring that PSA down and decrease the time until somebody develops metastatic disease. But we want to know if we can improve on that. And mostly we want to know, can we give something with different side effect profiles? As a lot of people know out there, when we bring your testosterone close to zero, men can get hot flashes, their libido goes to zero, there's an increased risk for osteoporosis, gynecomastia can be an issue, and even atherosclerotic cardiovascular disease can be an issue. And these are just a couple new slides of new things that we have in the medical oncology component of prostate cancer that's coming up this past year. One is this trial, the EMBARK study, where we're looking at the hormone therapy, which is Leuprolide, in patients that have a rising PSA after prostatectomy or radiation. And we're comparing it to giving a novel hormonal therapy, such as enzalutamide, which has a different side effect profile, versus a combination of the two of them together, enzalutamide and Leuprolide. And you can see, and we can see from the graphs here, and I know it's pretty busy here, that giving two gives you better outcomes together. But if you compare just the enzalutamide pill to the hormone shot, the Leuprolide, the enzalutamide monotherapy can be superior, and that means decreasing the time until a patient has metastatic disease, and you could potentially prevent the development of a lot of these Lupron and hormonal related side effects. So this is a big change that we've seen in patients that have PSA-only recurrent prostate cancer in the non-metastatic setting. I want to also talk about using our novel hormonal therapies, our ARPIs, androgen receptor pathway inhibitors. Traditionally, we've used Leuprolide in patients that have metastatic hormone-sensitive prostate cancer. Over the past few years, we've used these ARPIs, which are novel hormonal therapies, which have novel mechanisms of action. And when they combined with Leuprolide, these other traditional hormonal agents, we see unprecedented rates, changes in overall survival, and the time to developing metastatic disease while preserving quality of life. We know also a substantial proportion of our patients with metastatic prostate cancer have mutations in BRCA-related genes or BRCA-related genes. We call those HRR genes. And we have pills that bind to these genes, but only around 10 to 15% of patients qualify for these pills. So there's been a lot of work in the past few years seeing how can we give some of these pills to patients that don't have these types of genes, these HRR genes. And we know they work together. So there's been trials now, and I know this is a busy slide, but I just want to cut to the chase on this, combining these novel hormonal therapy pills, such as enzalutamide, which I talked about, with these other pills called PARP inhibitors. And we know, and when you give them together in patients that have these BRCA mutations or BRCA-like mutations, they have better progression-free survival, or the time until they have growth of their cancer. But we also know now that in patients that don't have these, we're seeing better outcomes as well. And although those aren't FDA approved yet, I do anticipate at some point the combination of these novel hormonal therapy pills with these gene binding pills that bind to BRCA-like genes called the PARP inhibitors will be approved for patients with metastatic disease, whether they have these mutations or not, which will open up a whole new world of treatment options for patients that don't have these recurrent genes, which is fantastic. I want to talk a little bit about PSMA as well. Big change in the prostate cancer field. Dr. Saeed from radiation oncology just talked about it. PSMA stands for prostate specific membrane antigen. If you take a sample shown on the graph on the right, if you take biopsy samples from all kinds of different tumors, lymphomas, melanomas, medulloblastomas, pheochromocytomas, etc., you don't see any of this PSMA expression. But in prostate cancer, you see it at very high levels, which makes it a very attractive target to try to create a drug to bind to it, to destroy the prostate cancer. And that is what has been developed here. And Dr. Saeed was talking about this drug called Pluvicto. It's also known as, which is a mouthful, lutetium-177 PSMA. It is an antibody that binds to that molecule on the surface of your cell called PSMA, and it has a piece of radiation attached to it. Once it binds to the molecule, it's engulfed by the cell, and then inside a little vesicle inside the cell, it releases the piece of radiation so it can cause DNA damage and toxicity to the prostate cancer cell, and ultimately that cell dies. And the important thing here is that not just giving this piece of radiation alone without the antibody to the PSMA, or else it will get absorbed by every cell inside the body. So we can give targeted radiation to our prostate cancer cells. And the big trial for this was what's called the VISION trial, where we have patients that have metastatic prostate cancer that is resistant to our hormone therapies. Traditionally, a lot of these patients have had not great outcomes. They've had chemotherapy, they've had other hormonal therapies, these novel hormonal therapies such as enzalutamide I've spoken about before. They've been on the leuprolide hormone therapy as well. Some of them have those BRCA mutations or BRCA-like mutations and have been on those PARP inhibitors as well. And they compared giving this drug called Pluvicto or lutetium-177 PSMA to dealer's choice, whatever the medical oncologist wanted to give them, usually some form of cytotoxic chemotherapy. And we've seen unprecedented results. You can see the patient on the left before they started their Pluvicto therapy, their PSA was greater than 100. And all those black dots, for the most part on that on the scan here, represent metastatic prostate cancer in the bones. After the first cycle of this Pluvicto therapy, you could already see all those black dots starting to light up, which means that we're having significant tumor shrinkage at this point. After just 2 doses of this, you can see this patient had another specialized PET-CT scan, and you can see barely any cancer left in their body, and their PSA went from greater than 100 all the way down to 0.6. We now offer this at Lynn Cancer Institute. It is approved by the FDA for patients with metastatic castrate-resistant, that means hormone-resistant prostate cancer that have received chemotherapy in the past, and at least one of those novel hormonal therapies that I spoke about in the beginning. Now, of course, we still have more work to do with this. How can we make Pluvicto better? And that's where a lot of the research is coming in. Combining agents with Pluvicto to increase response, potentially decrease toxicity that we can see with Pluvicto, which can include lower blood counts and dry mouth and dry eyes, and increase survival. We're also looking at potentially retreating patients that have had excellent responses to Pluvicto, giving them a break if they have growth again, giving them a few more cycles. And then over time, the real question is Pluvicto going to move up front? Are we going to start treating patients with metastatic prostate cancer with Pluvicto earlier in their course? Is chemotherapy going to become a thing of the past for metastatic prostate cancer? And I hope that becomes true someday. So I know this was short and sweet. But if anybody has any questions, please let me know.
Thank you so much, Dr. Bacco. I believe, can the 3 physicians see the Q&A box? There's 2 questions. Let me know if you can see them and who would want to answer them.
I can take those for now, and then if anyone else wants to jump in. So, I think that prostate exams are still important. I do it the first time I see a patient and every year. Now, if they recently had an MRI that was clean, I think we could skip it. No one really wants to have an extra prostate exam if they don't have to. But it's an important thing to get every so often. On surgery and radiation, the risks of surgery are much higher after the prostate has been radiated, but it is a doable surgery. We do what's called salvage prostatectomy here when necessary, a couple times a year, and most patients do very, very well. But there's the risk of incontinence from surgery is probably 1% long term if it's a virgin or a first primary surgery. For salvage, it's maybe more in the 20-25% range of urinary leakage. So the risks are a bit higher, but certainly it's a doable procedure if it's necessary. But with Dr. Saeed's expertise, we rarely see any radiation problems.
Any other comments, doctors? Thank you, Dr. Taub. Okay. Oh, I see one more question. Oh, do you see the third question?
So I see it. So
Okay,
question is somebody that had high risk prostate cancer, Gleason 9 disease, that had a radical prostatectomy, and they have a rising PSA. And the question is when to do the PSMA scan. And we ask ourselves this question once a week at our genitourinary multimodality tumor board. We take multiple factors into account: what the patient's original pathology was, what their Gleason score was, and we look at the PSA velocity as well. It really depends on for the patient. Traditionally, a lot of times we're saying 1.0, but if somebody has a rapidly rising PSA with a PSA doubling time, that's less than 6 months, or they're having any types of symptoms, we'll go ahead and get a scan a little bit sooner. But a lot of times we'll just increase the screening of how often potentially we check a PSA.
okay, thank you. That looks like all the questions that are in the chat box. And thank you, doctors. That was really, really very informative. And it's just amazing how we all learn something new every year. So we appreciate your time for doing the research on this and presenting to us. To the audience, all our lectures are recorded. So if you'd like to go back to review any of the information that was presented today, you can just let Lee or myself know, and we can send you the link. Lee will be sending out an evaluation form, and at that time she can easily send you the link so you can look at this lecture again or share it with anyone that you feel would benefit from it. We appreciate all of you who have joined us today, and we'd like you to know that our next presentation will be on Wednesday, September 25th. It will be from our nutrition series, and the topic will be nutritional guidelines for blood cancers, and it will be presented by our oncology dietitian, Katie Lauterbach. On October 16th, we'll be having our annual physician panel on breast cancer that will feature 8 of our physicians. So that's a very worthwhile lecture to participate in as well. And on that Saturday, we're bringing back our Breast Cancer Bazaar, which will be live here in our Lynn Cancer Institute. It will provide education on breast cancer, shopping for all the women that come, and we'll also be offering complimentary skin cancer screenings. On October 30th, will be the next in our series on our nutrition series. And I wrote down the wrong topic for that. So tune in. And so thank you, doctors. Thank you for everyone that is joining us today, and have a good day. Good weekend. Bye, everyone.